All right, so I'm going to throw it out to you guys before we kind of get started with the quiz for today. If you have any questions to clarify before we kind of get started for today's class. If you'd like to use scratch paper, you're welcome to do so. So you can go grab some paper right now. You won't need a calculator for this quiz. There is one built into Lockdown Browser, but you won't need it. If there are problems with Lockdown Browser or Respondus monitoring, just shoot me a message. I know a lot of times last semester students would get kicked out and they would have to log back in. If you do have to log back in, it should pick up from where you left off in the quiz. Okay. There are 25 questions on the quiz. So once you're finished your 25 questions, you're done. The quiz, you have 50 minutes to finish the quiz, and then we'll take a 10-minute break after the quiz is done. Okay. If it becomes a big problem for the class, which I have had problems with Lockdown Browser and Respondus, I can go in and turn those off, but they do want us to try and use those this semester. Okay. All right. So if everybody's ready, so you're going into Lockdown Browser and you're looking for week 2, quiz number 1. And I'm going to type the passcode into the chat bar. Okay, so it's week 2, quiz number 1, and the passcode to get into the quiz is first quiz. So you can go ahead and log into your Lockdown Browser. There is a space in between first quiz, and quiz are capitalized. So once you're in, you can go ahead and start. Hey, Mike, so what did you think of the test? Was it kind of the topics that you thought would be covered? Was it?
It'll work.
All right.
I'll
I,
let you
I
know
did.
after I'll let you know after I see my score.
All right. All right. Sounds good. So there was some questions about a couple of the questions towards the end. So that's usually why I don't like to post the scores right away, is because I want to make sure that all the questions were valid. And if I need to return points to students, I do. So I do look at those tomorrow and look at the analysis of the questions as well to make sure that they were valid questions.
There were a few that they were set up for SATA, but they weren't written as it didn't say a SATA question. So we're like,
Right, right. So I think people were telling me 17 and 18, so I'll have a look at those ones particularly, but I do go through it and make
uh,
sure that it's all fair for everybody.
yeah, I think I like 16, 17, 18, 20. It was like a good five of them. I was like,
Yeah, yeah.
I'm going to go out on a limb and say these are just regular.
All right. Well, I will certainly have a look at those and we'll balance the scores appropriately. So, yeah.
Hmm. There was that one about complications to ARDS, and I'm even looking at it here, but I'm kind of wondering, wouldn't ARDS cause CHF?
It was looking at the complications of treatment for ARDS, I think is what the question was. And so it goes back to the renal failure,
Mm-hmm.
um, the barrel trauma, volume trauma.
Mm-hmm. Yep, I found it, but I was like,
Okay.
hmm, oh well, I'll take the hit.
Yeah, that's okay.
Damn it. Everything but heart failure.
Yeah. So for those of you, I'll wait till 6 till everyone's back. But for those of you that are online, so usually what I do is tomorrow I'll have a look at the quiz itself, make sure that the questions were worded correctly. May have a look at the analysis because Canvas gives us a quiz analysis, and then what I do is I remove any bad questions and give the points back to the students, and then I release the results. So that's kind of how I do all the quizzes. That way, you guys are able to get the maximum scores that you can. It's fair for everybody. And if a question was worded incorrectly or formatted incorrectly, or if the analysis comes back and says, hey, it was just a bad question, then those are removed. Okay, so that's kind of why I do it that way. Because I know in the past, then students get kind of bent out of shape if scores change and different things like that. So that's kind of what I do.
Well,
Okay.
based on that, you could throw out the entire NCLEX then.
So those are peer reviewed. So it should be good. And then pretty full schedule for this class. We'll keep going with our respiratory conversations and look at some case studies and those kinds of things. So it should be good. And then same thing with manager of care. We'll do the quiz at the beginning of the next class. So I'm not sure if we'll get to delirium tonight because it doesn't. I think I'd rather kind of finish respiratory and ventilation if we can. And then I'll do delirium at the end, just because delirium is kind of a separate topic, but it will not get missed. So hopefully the ATI tests will help a little bit. Some of the material, Whitney, that was covered on the ATI respiratory, we'll kind of go over in class today. So we'll kind of see. I find the critical care course challenging to teach because the amount of content is so big. It's a lot of content to fit in. So I don't know if adding another pretest would help or not.
To be honest, I was hoping we were going to do the EKG component back in fifth or even fourth block.
Mm-hmm. Did you guys do normal sinus rhythms at least?
That's it. But even then, that's like,
Okay.
I don't know. It's just like, okay, this is how you stand up and then get out. I'm trying to throw
So
it back in last semester.
well, I usually try and do the ventilators first and then the rhythms because usually that kind of helps with clinical if you are going to clinical. So we'll kind of see what your clinical experiences are like this semester.
All
All right. I think most people are back. So we're going to start by looking at the case study for Sally Peters. So if any of you guys printed it out or if you just want to kind of follow along on the screen, I'll wait a couple more minutes here. It's about 3 minutes before 6, and I said 6. So, and we'll just kind of talk about Sally Peters from a respiratory standpoint. If you didn't print it, you don't have to. You can kind of follow along on the screen. It's just to kind of pick up like key points in case studies and kind of what you should be focusing on. We'll kind of go through that.
Oh, by the way, if anybody's got kids that are going to the Gilbert Public Schools district, they are going back full time on Monday.
Whoa, that's exciting.
I got a band director friend that just put it out on Facebook. So yeah.
My daughter goes to a charter school, so they had only 1 week online, and then the rest they've been going in person. So it's been good. All right. Okie dokie. So, before we get started, I'm going to go ahead and share my screen, and I'm just going to show you some extra material that was kind of added in the modules for this week. So, if this works, there we go. Okay, so this is week 1. Okay, so this is week 2 right here, okay, that we're on right now. And the additional learning materials, if you click right here, oops, that's not that one, that's week 3. That's next week. Week 2, this one. It's not going to work now. Oh, I made week 2 disappear, that's why. Okay, finally, week 2. So this is just some additional learning material that I put in the module for this week. There is a handout on different oxygen systems and the percentage of oxygenation you have. There's a article on ventilations and on ventilators. There's a tip card from on ventilators. The American Association of Critical Care Nurses released all of their reference cards, these pocket cards. So this one and this one, they're usually about $10 a piece, but because of COVID, they released them all free. So I uploaded those. There's a rapid sequence intubation, and it's a one pager. So these are some really great one page handouts that you can kind of keep in a clinical book or kind of keep for your own reference. Okay. So hopefully those are helpful. All right, so that's where those are. So we're going to go ahead and get started with looking at our case study for Sally Peters. Okay, so I'm just going to go ahead and start reading a little bit about her. So Miss Sally Peters, she's 45 years old. In 2013, she sustained a C4, C5 complete spinal cord injury as a result of a spinal bleed following surgery. Sally's prognosis at first was poor, and she has been discharged for home for palliative care. However, she's been doing better than expected and usually lives at home with her husband. Miss Peters was never able to be weaned from the ventilator, and as a result, she had a tracheostomy to help with secretions and ventilation. She spent several months in the spinal unit in 2014 prior to her discharge. Sally is able to breathe for short periods of time without the ventilator, but becomes very tired. So she was discharged home with the ventilator. She requires oxygen therapy, nebulizers, regular suction throughout the day. She's been readmitted 2 days ago for increased congestion and now needs to be suctioned. So Daniela, just looking at her history, what kind of stands out to you as things that you would be concerned about?
Sorry, can you hear me?
Yeah, go ahead.
Okay. Her white count.
So just on her history. Just on her history.
I'm sorry.
Yeah, that's okay.
The C4, C5 injury with the spinal bleed.
Okay.
And then her prognosis being poor. She's on palliative care. She was never able to be weaned off the ventilator.
Awesome. So C4, C5, why does that affect our ventilation? What do we need to breathe? What muscles do we need?
Your accessory muscles, is that doesn't that paralyze from the shoulders down?
Yeah, so her injury is pretty high, C4, C5. So C4 innervates the diaphragm, yeah. So if she can't move her diaphragm and she can't use her accessory muscles, will she be able to take an adequate breath on her own?
No.
No, right? So that's why she's ventilator dependent, okay? So if she can't take a breath on her own, will she be able to cough on her own?
No.
No. So why is she becoming more congested? What's the concern there?
It's because she's unable to move the secretions. Is that correct?
Right. She's not able to clear her own secretions. So what is she at high risk for?
Pneumonia.
Pneumonia. Yeah. So just looking at her history, C4, C5. So not only, so she's probably bedridden, correct, or at least minimally in a wheelchair for activity. So she's high risk for pneumonia because of immobility. She's high risk for pneumonia because she can't clear her own secretions. She can't deep breathe and cough. She can't ventilate on her own. And I'm not sure what her nutrition status would be either. Okay, so those are all kinds of things just from her history that you would be kind of wanting to look at. Okay, so Mercedes, looking at her medication, she's on ibuprofen for muscle pain. She's on Effexor and Xanaflex. Are those appropriate medications, do you think, for her? Yeah, so she has some muscle pain again. That's probably from the spinal cord injury. So she's got some pain medication for that. And then it says in her history she has a history of depression. So she's on Effexor for her depression. Okay. All right, Polita, what do you want to do with her labs? What do you think about her lab values?
Everything looks okay except the sodium is low.
Okay, so sodium is a little bit low, right? You want like 135. Her potassium is a little bit low, so that you want that to be about 3.8. Okay.
I mean, but
Creatinine is
normal is what,
okay.
3.5 to 4.5?
Yeah,
Just a
yeah,
little bit lower. Mhm.
yeah. And then her white count's a little bit elevated as well. Okay. Are there any other labs that you would want to know for her, or any other testing that you would want to do for her?
I would probably test her sputum and do a chest X-ray and check to see if she has infiltrates, which could indicate she has pneumonia.
Awesome. Great
And then
job.
I probably would add fluids to get her IV fluid so it can dilute the secretions.
Yeah, yeah. So you want to make sure that she's really well hydrated so her secretions aren't sticky. And then again, you would want to look at her nutrition status. Is she able to eat with the tracheostomy, or does she have a feeding tube? Is she getting adequate nutrition that way? Okay, awesome. And then Lena, what do you think about her vital signs? Her blood pressure is 122/70 with a respiratory rate of 18. Heart rate is 66. O2 sats are 98%, and her pain is a 4 out of 10.
I think it's pretty normal for the most part. Temperature, I think it depends on if it's climbing, like what her previous one was, but I think that's still in the normal range, I believe.
Yeah. Yeah, so her respiratory rate is good, so she's ventilating well, okay? And she's oxygenating really well. Her O2 sats are 98%, okay? So Michael, what kind of nursing diagnosis would be your primary nursing diagnosis for her? What do you guys think of?
I would consider, just because of the trach, impaired gas exchange, but she's got good gas exchange for now.
Yeah, so you could do maybe something like altered breathing pattern or something like that. Okay, but yeah, you want to focus on her breathing.
Maybe ineffective breathing related to the injury.
Yeah, ineffective breathing related to C4, C5 fracture. Yeah. Awesome job, you guys. So that's kind of how you kind of work through some of these case studies. You really want to glean like a lot of detail from the history. You can get a lot of information and kind of know what you're focusing on. And so that's kind of your SBAR report, that history. So you knew already just from her injury what kind of ventilation issue she's going to have, right? Any questions on Miss Peters? No? All right, so that's kind of a basic ventilation kind of case study.
So I have a quick question. When it comes to the vital signs, so the only thing that stuck out to me kind of was like the pain. So just because if there's any level of pain, we want to try to treat it. So just for like real life, when they say 4 out of 10, like would that kind of be like, okay, we need to get right on that? Or is there like a real life scenario where depending on the level, how, you know what I mean?
So typically I would go back to her medication. So she has ibuprofen and the Xanaflex. So I would go back to my questions for pain. Where is your pain? What's the quality of your pain? Is it related to muscle spasms? And then I would go ahead and I'd probably give her Xanaflex.
Okay, so any type of pain, if it's not a 0, even if it's a 1, that would be like an abnormal finding because they should not be in pain, right? Okay,
Yeah.
just to make sure I'm thinking right. Okay, thank you.
Yep, perfect. All right. All right, perfect, you guys. All right, so let's do a quick review of ABGs. So let me change the slide deck here. Okay. So you guys talked about ABGs quite a bit last semester, correct? Okay. So this is just a very quick overview of ABGs. So basically, when you're looking at your ABGs, you're looking at maintaining that pH balance. Okay, so it's that acid-base balance. There's a lot of health concerns when you have an imbalance, and there's a lot of problems that can lead to it. So the things that we look at, some of the metabolic problems are related to diabetes. Some of the respiratory problems, like we've talked about, are related to restrictive airway diseases like asthma, COPD, or pneumonia. Okay, kidney disease would be another one that would cause some metabolic dysfunction. So when you're looking at your pH, your normal pH is 7.35 to 7.45. 7.4 is your middle ground, okay? So even if it's compensated, that's how we figure out if you're on the acidotic side or on the alkalotic side. If it's less than 7.4, you're on the acidotic side. If it's greater than 7.4, you're on the alkalotic side. So there's two systems that kind of help with your pH balance, your respiratory system and your renal system. Your renal system, this is your buffering system. It usually takes about 24 to 48 hours for your renal system to kick in, where your respiratory system acts right away. Okay, so the easiest way or the quickest way to change an acidosis or an alkalosis is to change the way we breathe. Change the respiratory system and you can move your pH, okay? If your respiratory system, you've done everything that you can and you're still on the acidotic side and your buffer system is impaired, that's when you'll see them add medications like sodium bicarb. And you can hang that in an infusion on a continuous drip, or you can give it IV push. Okay, if you're in a code situation and it's a known acidosis, a lot of times they will give sodium bicarb IV push, and it comes in a really big 50 ml ampule, okay, that you have to kind of push really hard. It's very sticky and thick. So we kind of talked about the regulators. So again, that respiratory system is the one that functions the best and the first. So it responds in minutes, whereas your metabolic system does take a lot longer to change. Okay, so we have a lot of chemoreceptors that pick up changes in our pH in our bloodstream, and what that does is it sends a message to our brainstem to change how we breathe. Okay, so that's how we kind of automatically do it, and we do it all the time, and we don't have to think about it. It's one of those autonomic functions of the body. Okay. So when you're looking at the renal system itself, the renal system is responsible for secreting hydrogen. It combines it with ammonia and excretes weak acid. So this is where your urea comes from, and that's how it gets rid of acids in your urine. So imbalances can occur for a lot of variety of reasons. Again, it could be a chronic imbalance, something like chronic COPD, or it could be an acute change like ARDS, or some kind of a metabolic acute change like DKA. So when you're looking at your blood gas values, you want to look at your pH. That's going to tell you your acid-base balance. Your CO2 is going to tell you your ventilation, and your CO2 is what changes your pH. Okay, so ventilation is pH and CO2. Your PaO2 is your oxygenation, and your SaO2 is your oxygenation. Your bicarb, obviously, that's your base, so that's your metabolic function. So your normal pH is 7.35 to 7.45. Your normal PaO2 is 80 to 100. Your normal CO2 is 35 to 45. And your normal bicarb is 22 to 26. And then your O2 sat would be greater than 90%. Go back one slide. Sometimes they'll have a base excess on there, and it's usually a negative number. This base excess just gives you an idea of fluid status as well. So if they are very negative on their base excess, it tells you that the patient's dehydrated. But we don't use it to do ventilation or anything like that. It's just another reference number. So the first thing you want to do in interpreting your ABGs, I did put that Rome kind of trick on there under the additional information if you use Rome. But you want to look at your pH. Again, 7.4 is your middle number. If it's less than that, you're acidotic. If it's greater than that, you're alkalotic. Okay, and then you're going to look at your CO2. Okay, if your CO2 is high, or if your CO2 is low. Okay, so if you're, and then remember your CO2 is an acid. Okay, so if your CO2 is the problem, then it would be a respiratory issue. If your bicarb is a problem, then it's going to be a metabolic issue. Okay, and then your O2 and your O2 sat, this is just specifically looking at oxygenation. Okay. So this is Rome. I personally don't like Rome. I know a lot of nursing students do, so have at it. I like to look at the numbers, and to me, I need to think in my brain physically what's going on in the body. So Rome just confuses me. But if it makes sense to you, perfect. So O2 sat, you want above 90. Greater than 95, that's great. Okay, so but 90% is kind of your low. So I put these little pictures on there as well for the respiratory acidosis, alkalosis. So again, you can have compensation mechanisms. So if you have a patient that's compensating, you'll see a compensation on the other mechanism. So if it's a problem caused by a respiratory failure, you'll see compensation with the bicarb in the opposite direction. Okay. And we're going to look at some case studies and kind of go through them so we can have some practice. Same thing on the opposite side. If you have a alkalosis problem, again, you'll see compensation on the opposite side, and you'll start releasing some of that bicarb. And then these are just some things that you normally see for acidosis. So ketoacidosis, that's talking specifically about diabetic ketoacidosis. And a lot of times we actually see a mixed gas with DKA, and we've got a couple of examples of mixed gases. Lactic acidosis, we talked about lactic acidosis when we talked about hypoxia. So again, if you're hypoxic for a prolonged period of time, you go into that anaerobic metabolism state and you start to produce lactic acid instead of CO2 and water. And so you become a lactic acidosis, which leads to cellular death. Okay. Severe diarrhea, kidney disease, those are other things. Vomiting is another one where you'll see changes. And then your metabolic alkalosis. So again, if you have a lot of vomiting, you have an NG tube in, and you're losing a lot of acids from your stomach that way, you'll go into a metabolic alkalosis. So if you think about it, acids come out, bases are at the bottom. Okay, so if you're pooping and you have diarrhea, you're going to lose all your base. If you're puking, you're going to lose all your acid. So if you think about heartburn, this is all acid coming out of the top, and then you lose a lot of bicarb with your diarrhea. All right, so I think that's it for that one, 17 slides. So let's look at some case studies for ABGs. Okay. All right, so Alicia, I'm going to have you kind of figure out this first one. So this first one is Mr. Frank. He is 60 years old with pneumonia. He's admitted with dyspnea, fever, and chills. His pH is 7.28. His CO2 is 50. His PO2 is 70, and his bicarb is 25 with a SAT of 89%. So how do you go about interpreting this ABG?
So your pH is below 7.35, so it's acidic.
Mm-hmm.
CO2, that is above 45. So respiratory acidosis, but his PO2 is a little bit low as well.
Okay, so if this is outside of the normal, is this compensated or uncompensated?
Uncompensated.
Right, it's an uncompensated respiratory acidosis. Okay, is he hypoxic?
Yes, because his O2 is below 80, so he's like
Right,
moving in
right.
that direction.
Yeah, great job. So yeah, so this is an uncompensated respiratory acidosis with hypoxemia. Okay, so why is his respiratory rate 56? What's going on with him?
He is trying to increase the amount of oxygen, but he's got too much CO2 retention. So he's just getting, what was the word?
So why does he have CO2 retention? What does it tell you up here that tells you he's going to be retaining CO2?
Oh, the pneumonia.
The pneumonia, what else?
Dyspnea.
Dyspnea, right? What does dyspnea mean?
It's like the rapid short of breath.
Okay, so if he's short of breath, can the CO2 be breathed out?
No.
No, right?
Shallow.
Right. So the dyspnea is why his CO2 is high. The pneumonia is why his PO2 is low, right? Because pneumonia is an infection of the alveoli. Okay, so that's going to cause my oxygenation problem. My dyspnea is causing my ventilation problem. You guys see that? Okay, so this is kind of why I said last week, really try to think now about separating out your ventilation from your oxygenation because they occur for different reasons and you're going to do different things. Okay, so what are we going to do? What intervention are we going to do to fix his ventilation? What do you want to do?
Give him supplemental oxygen.
If I give him oxygen, is it going to fix his CO2?
Oh, no. Weren't we told last semester that they like breathe in a paper bag or something?
Okay, so what would be another way to teach breathing?
Oh, the pursed-lipped breathing.
Yeah,
or
yeah.
sitting in the tripod position.
Right, right. So you want to try to slow his breathing down, or to be able to get him to breathe and ventilate better. Okay, so you could do some pursed lip breathing. You want to sit him upright. Oxygen, absolutely. Oxygen is going to help your PO2. Okay, what other medications do you think might help with this patient?
It depends on what kind of pneumonia he has, but antibiotics might be a good way to go. Antipyretic, and then a anticholinergic for the mucus.
Yeah. So someone, Lindsay put in here bronchodilator. Yeah. If I give him a bronchodilator, is that going to help my CO2? Yeah, right. Bronchodilators are going to open up those airways and let that CO2 escape, right? So that's why your bronchodilators are helpful. What other medication is going to decrease my airway swelling that you see a lot? Steroids. So it's a big hot topic now with our COVID patients, right? Is giving them steroids. Okay. So a lot of patients, you want to give them steroids to decrease inflammation, bronchodilators to dilate the bronchioles so that I can correct my ventilation, teach him some pursed lip breathing, give him some oxygen. And boom, we got Mr. Frank all fixed up. Great job, Alicia. All right, so here's the answers for Mr. Frank, if you didn't get them. So again, you don't have to write all the notes down here. They're all in here. On here, it mentions some other things that we haven't really talked about yet. We'll talk about these in a little while. CPAP or BiPAP. CPAP stands for continuous positive airway pressure, and BiPAP stands for bi-level positive airway pressure. So we'll talk about the difference between CPAP and BiPAP, okay, because that could be another treatment option for Mr. Frank. All right, any questions on Mr. Frank? No? All right, next up, we've got Dawn, and we're going to have her kind of look at Miss Strauss. All right, so Miss Strauss is 24 years old, college student, history of Crohn's disease. Do you guys know what Crohn's disease is? Yep, okay. Complaining of a 4-day history of bloody, watery diarrhea, and her blood gas is below 7.28. Her CO2 is 43. Her PO2 is 88. Her bicarb is 20, and her SATs are 96%. So Dawn, what do you think is going on with Miss Strauss?
Well, her pH is low. It's acidotic.
What's causing her acidosis?
And
the
bicarb is low as well, so it's metabolic acidosis.
Awesome. Is it compensated or uncompensated?
I would say uncompensated.
Correct, because it's outside of the normal, right? It's outside of that 7.35 to 7.45.
Mm-hmm.
Great. All right. Is she hypoxic, or is her oxygenation okay?
Her oxygenation is okay. It's good at 96.
Yeah. So she's got an uncompensated metabolic acidosis. Okay. So what do you want to do for her?
This is the part I'm bad at.
Interventions. She's had a 4-day history of bloody, watery diarrhea. Your team's helping you out there in the chat bar.
Oh, give her some fluids.
Yeah. See, nursing's a team sport. Yeah, you want to give her some fluids, right? You might want to draw some other labs, see what her potassium is, her sodium is, some electrolyte replacements. Yeah, Alicia. Okay, maybe check what her hemoglobin hematocrit are if it's been bloody. Okay, so yeah, great job, you guys. Good to help each other out. Okay. So this is Miss Strauss. Miss Strauss has uncompensated metabolic acidosis due to the bicarbonate loss from her diarrhea. So again, your diarrhea is going to be your bicarb coming out of the bottom. Acid comes out of the top if you're vomiting or you've got an NG tube in. Okay, so that's kind of an easier way to remember it. So again, it would just be kind of, compensating. She's only 24, right? So she's young. She should be able to compensate. She just may need some fluid replacement. Okay. Any questions on Miss Strauss? Nope. All right. Let's see. Amanda. Mr. Carl. All right, so Mr. Carl is 80 years old. He is in a nursing home and he's being admitted with urosepsis. So what is uro? Where does uro come from? That name? Urinary, right? And what is sepsis? Infection, right? So urosepsis is a septic condition from a urinary tract infection. Okay, so it's a urinary tract infection. If it was a bloodstream infection, that would be from a central line, but uro is letting us know that it's from his urine. Okay, so over the last 2 hours, he's developed some shortness of breath and he's becoming confused. His ABG, he's in trouble. 7.02, his CO2 is 55. His PO2 is 77 and his bicarb is 14. Oh, poor Mr. Carl. So what do you want to do for this poor guy? What do you think's going on with him?
Well, he is compensated metabolic acidosis.
So what's causing his acidosis? He's a severe acidosis, right? 7.02.
Mm-hmm.
So what's causing his acidosis?
Sepsis and shortness of breath.
Okay, so when I look at his ABG, is it a respiratory or metabolic or both?
It could be both.
It's both, right? See, his CO2 is high and his bicarb is low. So he has a mixed gas. Okay, so he is in a metabolic and a respiratory acidosis. Is he hypoxic?
Yes.
Yeah, so he's in bad shape. He's in an uncompensated metabolic and respiratory acidosis with hypoxemia. Okay, does this kind of tell you why he's confused?
Yeah, he's hypoxic, so usually a sign.
Right. So what would you expect his behavior to be? Is he going to be pulling at his gown, trying to climb out of bed?
Yes.
Agitated, irritable. Yeah. So all those early signs of hypoxia, he's going to be them, right? So he's going to be high fall risk. He's going to be pulling his IVs out. He's going to be pulling on his Foley catheter. He's going to be pulling his leads off. He's going to be naked in the bed. And squirrely, trying to climb over the side rails, all those kinds of things. Okay. So yeah, Whitney, if we had some vital signs in here, he's probably going to be tachycardic and he's going to be hypotensive because CO2 is a vasodilator. So I'd expect his blood pressure to drop as well. So this is kind of how you apply some of what you're seeing in your ABGs to some of your signs and symptoms that you see and why they behave this way and why they have these signs and symptoms. Okay. So what do we need to do for him? He has urosepsis. What do we do for sepsis? So antibiotics. Fluids, oxygen. So am I going to be able to correct this just with regular oxygen, or does he need more help than that? He needs a lot more help, right? So this is your critical care type of a patient. He needs some kind of a mechanical ventilation, maybe a non-invasive one. We would have to kind of see how he would tolerate it, but he's already symptomatic. He's already confused, okay? His pH is severely acidotic. His CO2 is 55, so he's not breathing well and he's not oxygenating well. So we need to fix both of these. And a really nice way to fix both a ventilation and an oxygenation is using BiPAP. Okay. CPAP, we'll have a look at CPAP. CPAP is only one pressure. It's a continuous positive airway pressure, so you only get one ventilation pressure. But in BiPAP, you get two pressures. You get an inhalation pressure and you get an exhalation pressure. So it helps with both ventilation and oxygenation. Okay. All right. Good job, Amanda. We'll kind of see the answers from Mr. Carl. All right. So yeah, looking at his presentation of sepsis and his respiratory failure, it is consistent with ARDS because he's having a respiratory and a oxygenation problem. Your treatment would need to be aggressive because he is severely acidotic. And he would probably need mechanical intubation or ventilation. Okay. So it just kind of says he needs to be in the ICU to be able to fix all of that stuff. Okay. All right. Any questions with Mr. Carl?
I have a question.
Yeah.
So I understand being like irritable and altered level of consciousness because he doesn't have enough oxygen and all that. But like as far as the restlessness and like erratic behavior and clawing at himself and stuff, to me in my mind, I look at that and I'd be like, he's like half dead, hardly conscious. How is he gonna get that crazy to be pulling IVs out and stuff? Like I feel like I wouldn't have the energy to do that.
You would be surprised. Little old ladies and little old men, oh my gosh, they can be super strong. So, yes. So that's when you kind of go into that fight or flight. So if you think about you can't breathe, you really start to release all those epinephrine and your norepinephrine to try to fight to breathe. And so a lot of times those patients can be quite strong.
Okay, that makes more sense.
Yeah. If your CO2 goes very high, like 80 or higher, that's when your patients will become obtunded and difficult to arouse. You won't be able to wake them up. Okay. So, but hypoxia, they are air hungry and they are panicky because they have this sense of doom. They can't breathe. They can't get enough oxygen. And so they get very, very worked up and very tough to deal with sometimes.
Okay.
Yeah. Yeah. Good questions. All right. Anything else on Mr. Carl? Nope. All right. So we're going to move over to Whitney, and you can talk about Miss Lauder. So Miss Lauder, she's thin, elderly looking. She's 61 years old. She's a COPD patient. And then here is her ABG. So she's 737. Her CO2 is 63. Her PO2 is 58. Her bicarb's 35, and her sats are 89%. So what do you think about Ms. Lauder?
So her pH is within normal, but it's a little bit on the low side.
Okay.
Her CO2 is high.
Right.
So I would say respiratory acidosis, but compensated.
Correct. So this is a compensated respiratory acidosis. Is she hypoxic or is she okay?
She is hypoxic.
She is hypoxic, right? Is her CO2 normal for her presentation?
I mean, it's definitely high, I would say, but I don't know what would be considered normal for CO2 or for COPD.
Right. So would COPD have a normal or a high CO2?
Well, they're going to have some high, but I don't know if that's too high.
Right. Okay. So to figure that out, you said she's compensated, right?
Mm-hmm.
So which part of my ABG do I look at for compensation?
Your pH.
So if her CO2 is high, the opposite would be your bicarb, right? Okay.
Right. It affects your pH, right? So your
correct.
pH also, okay, yes.
Right. So if my bicarb has shifted, which it has, it's high, right? It's greater than 26. How long does it take for this to happen? Does it happen right away or does it take a long time?
24 to 48 hours.
Right. So if this has shifted, I know this is probably more of her normal because she's already compensated. Does that make sense?
Yes.
Yeah. So if I know she's a COPD and I know she's already compensated, this is probably where she lives. And the reason I know that is because her buffer system is already activated. Okay. And that's what's correcting her pH. So you're right. So she is a compensated respiratory acidosis, but she's hypoxic. Her PO2 is 58 and her SATs are 89%. So what do we need to do for Miss Lauder?
Give her some oxygen.
Give her some oxygen. Yeah. So even though she's a COPDer, okay, you still don't want them to be hypoxic. Okay, so if you remember that picture of the little COPD guy and he's sitting up over the bedside table, he has a nasal cannula on. A lot of times COPD patients do have oxygen. Okay, and a lot of times that kind of throws us off. We think that we shouldn't give them oxygen because it's going to block their respiratory drive, but we don't want them to be hypoxic. Okay, so a little low flow oxygen would be really good for her. Awesome job. All right. All right, Melissa, you want to do Miss Steele? Miss Steele is 17 years old. She's got intractable vomiting. So again, intractable vomiting, I know she's going to be losing a lot of acid and a lot of fluid and a lot of electrolytes. She has some electrolyte abnormalities, so blood gas is obtained. pH is 7.5, CO2 is 36, PO2 is 92, and her bicarb's 27. So what do you think about her ABG?
Okay, so she's alkalotic,
Mm-hmm.
and she is within the normal range for CO2.
Mm-hmm.
And her oxygen or her O2 is fine,
Right.
but she is a little alkalotic on the HCO3. So I would say metabolic alkalosis.
Right. So this is a uncompensated metabolic It's a acidosis or alkalosis. Sorry. Yeah.
Yeah, I'm sticking with alkalosis.
Yeah, alkalosis. Because this is greater than 7.4. So again, 7.4 is your marker. So this is higher than 7.45. So it's an uncompensated alkalosis, and it's related to her vomiting. She's losing a lot of her acid that way. Okay. So what would you want to do for her?
Definitely want to hang fluids. What does intractable mean?
Intractable means she can't stop.
Oh, okay. So I wouldn't want to have her push any oral fluids, really, if she's continuously vomiting. So we'd want to hang an IV, and probably pump her up with some Zofran.
Yeah. So some IV fluids, some Zofran, maybe an NG tube if she does have that much vomiting. Just kind of empty out her stomach because she would be at risk for aspiration. Yeah. Awesome. All right. Any questions on Miss Steele? All right. All right, we'll move on to Ms. Longo, Mr. Longo. Lindsay, did you want to have a look at Mr. Longo? He is 18 years old. He is a comatose quadriplegic patient who has the following ABG. So again, quadriplegic, I know he's going to be impaired, right? Just like Miss Sally Peters was. So his pH is 7.48. His CO2 is 22. PO2 is 96, and his bicarb 16 with a SAT of 98%.
Okay, so his pH is alkalotic. His CO2 is low. PO2 is normal, and HCO3 is low. I'm sorry, high. No, low.
Low.
So he is I don't know.
So he's alkalotic, right?
Yeah, he's alkalotic.
Okay. Is it compensated or uncompensated?
It's uncompensated.
Uncompensated. Okay. So if you're looking at alkalosis, okay, I know it's an alkalosis. Does a low CO2 or a low bicarb cause alkalosis?
Low bicarb. I'm sorry, low CO2.
Okay.
So he's respiratory alkalosis.
Right. So this is a respiratory alkalosis. So
I have a question. Would he be considered partially compensated because his bicarb is so low?
He would be a partial, yeah. Okay. So when you see a shift, but it hasn't gotten to within the normal range, that's when you say it's a partial compensation. Yeah.
Okay, thank you.
Yeah, sure. So what do you want to do for Mr. Longo? He's a quadriplegic. Is he ventilating okay?
Yes.
Is he? No. We said it's respiratory, right? So is he able to take a breath, a deep enough breath, and breathe out?
No.
No. So what does he need to do? Does he need more breaths or less breaths? Do I need this to go up or down?
You need it to go up.
I need it to go up, right? So do I need him to hold CO2 in?
No.
But I want this to go up.
Yes.
Yes. All right. So when you have a CO2 that is low, I want to make them retain more CO2. And the way that I do that is I decrease their respiratory rate. Okay? So, because I want him to retain more. I want him to keep it in. I don't want him to blow it out. Okay, so I don't know what his vital signs are here, but if he was breathing 26 or 30, right, I want to decrease that respiratory rate to keep CO2 in. Okay. So yes, even on a comatose patient, I want to normalize my pH and my CO2. Okay. That was a question from Mike. We used to have head injury and comatose people be more on the acidotic side, and we used to shift their CO2s because it helped decrease their intracranial pressures. But what we didn't realize that we were also doing is, again, this is a vasodilator. So when I vasodilate, I increase the cerebral blood flow, and so I make my ICPs worse. So we used to bag people. We used to call it bagging up or bagging down for head injury patients. We don't do that anymore because we learned that we were actually doing more damage than good. Okay, so that's an old practice. Okay, so we don't do that anymore. So you want to keep these in the normal range, even though he's comatose. Okay, you want to keep these normal. All right. Okay. Let's see. Mr. Casper. So Heather, did you want to do Mr. Casper? He is a 55-year-old with GERD. Do you guys know what GERD is?
Yeah.
Okay. He takes about 16 Tums a day. Oh my goodness. And his ABG is 7.46. His CO2 is 42. His PO2 is 86 and his bicarb is 29. Poor little guy. And his SATs are 97.
So his pH is slightly alkalotic.
Okay.
His CO2's in range. His PO2 is in range. His HCO3 is a little high, and his SH. So would he be? So it's metabolic alkalosis.
Right. So why is his bicarb so high?
Because he's taking too many Tums.
Right, he's taking too many Tums. Poor little Mr. Casper. So what do we need to change for him?
Stop taking 16 Tums.
Yeah. So what medication might he what you want to ask for instead of Tums?
For antacid, would that be like a PPI?
Yeah, proton pump inhibitor, right? Some protonics or something like that.
Something to help with the stomach acid, right?
Yeah, yeah. Good job. All right. All right. Let's see. Moving on to Miss Dobbins. This one's Stephanie. So Miss Dobbins, she's found pulseless and not breathing this morning. After a couple of minutes of CPR, she responds with a pulse and starts breathing on her own. And her blood gas is as follows: 6.89. Her CO2 is 70. Her PO2 is 42, and her bicarb is 13 with an O2 sat of 50%.
Hello, can you hear me?
Yep, go ahead.
So her pH high.
Is it high or low?
It's high.
Is it greater than 7.4 or less than 7.4?
I'm sorry. No, it's low. It's low.
Yeah, yeah. That's okay.
And then CO2 is on the acid side.
Correct.
Also. And bicarb is low.
Correct.
CO2 is way out of range.
Right.
So it's partially compensated respiratory alcohol or acidosis.
Is she compensating?
For the bicarb?
So this is low. So if my bicarb is low, am I going to be acidotic or alkalotic? if my bicarb was low?
It's acidotic.
It's acidotic, right? And this is acidotic. So this is another situation where you have a mixed gas, okay? So she's severely acidotic. So if you think about, again, go back to the description of what happened to her. She's been dead for 2 minutes. She was pulseless and not breathing, and she had 2 minutes of CPR. So she's in a uncompensated respiratory and metabolic acidosis. And the reason is because basically she was dead, right? So she wasn't ventilating and she wasn't oxygenating. Okay. So how good was her CPR?
Not great.
It wasn't great, right? Look how hypoxic she is and her CO2 level. So her CPR and her ventilation, I don't know who was bagging her and who was doing breaths, but they weren't doing a very good job, right? Okay. So whoever was on airway after the code, you need to have a debriefing and kind of say, hey, who was bagging her? Right? Because she wasn't getting any oxygen or ventilation. Okay. So what do we need to do for her? Can she stay like this, or does she need some kind of an intervention?
Are you asking me still?
Yeah.
Oh, well,
Just
she needs intervention.
So do you think she'll be able to maintain her own airway if she just came and had CPR?
No.
I see Polita shaking her head no, right? No. So this is a person that you want to intubate, put an artificial airway down their mouth and put them on a ventilator, right? She had CPR. She's acidotic, both ventilation and metabolic, and she's hypoxic. So she needs immediate intubation. Okay, you can't fix this any other way. She's too far gone. So sometimes when you look at your CO2 and your PO2, you probably won't see this in a textbook anywhere, but in clinical, they'll say they're in the 50-50 club. If your CO2 is 50 and your PO2 is 50, that is the 50-50 club, and that kind of means you need intubation. Okay, so you'll hear that in the clinical area, but I doubt you'll see it in a textbook anywhere. Okay, but that you might hear. Okay, all right, awesome job. So yeah, Miss Dobbins, she needs intubation. All right. Next one is Chelsea, and we've got Mr. Simons. So Mr. Simons, after you resuscitated Miss Dobbins, you find Mr. Simons to be in respiratory distress. Boy, you're having a bad day. He has a history of type 1 diabetes and is now febrile. Okay. His ABG is 7.0. His CO2 is 59. His PO2 is 86 and his bicarb is 14. So what do you think is going on with Mr. Simons?
So his pH is acidic. The CO2 is acidic as well as, and then the bicarb is. So he's in respiratory and metabolic acidosis with no hypoxia.
Correct, right. He's oxygenating okay, but he's not ventilating. Okay. So great job. So what other thing kind of stands out to you in his history?
The diabetes, because that can mess with the ABGs.
Right. So he could be, the metabolic problem could be related to DKA. And we'll talk about DKA when we get to endocrine. Typically, when we go into a DKA, we develop something called Kussmaul breathing, okay, where we breathe very fast. And that a lot of times creates the respiratory component of DKA. And that's why you end up with a mixed gas. Okay, so it's very, very likely I would need to get an AccuCheck on him and see what his AccuCheck level is and see if he is in DKA for this guy. All right. Good job. All right, this next one is for Michael, and this is Miss Birth. Miss Birth was admitted for a drug overdose. She's being mechanically ventilated. Her blood gas is as follows. Her pH is 7.54. Her CO2 is 19. Her PO2 is 100, and her bicarb is 16. So what do you think is going on with Miss Birth?
Okay, well, she's alcolytic, respiratory alcolytic, and she's partially compensating. Considering she's already on a ventilator, there's not much more we can do. Especially, how long ago was she had that overdose? Was it like just she's still working that off, or?
Yeah. So you might want some more information on her. Does she wake up? Does she follow commands? Is she breathing on her own on the ventilator? She's oxygenating really well, but yeah, you're spot on. She's a partially compensated respiratory alkalosis. So yeah, so you'd want to know, is she awake after this drug overdose? Because maybe she's oxygenating really well. Maybe she doesn't need the ventilator anymore, or maybe you can wean it down a little bit. Okay. All right. Good job. So that is it for ABGs. Any questions on ABGs? Do you guys want some more practice on those for Thursday? All right. So hopefully that was helpful. All right. So we've talked a lot about oxygenation and ventilation. Now we've kind of gone over ABGs a little bit, looking at CO2, PO2, okay, talking about how we can kind of change some of those things. So let's look at our ventilation patients. Okay. So there's different type of airways that you can put into a patient. Some are more temporary, and some are more permanent. So like Miss Peters, in that case study, she had a tracheostomy. That would be a more permanent type of an airway. All these other ones that we're going to be talking about are temporary airways. So an endotracheal tube is a tube that goes down through the mouth and down into the trachea. There's other tubes. This one has a different end on it. This is called a LMA. It's a laryngeal tube. There's other ones, King Airways. These are airway adjuncts. So this is a nasal trumpet or nasal tracheal airway. So this goes up in the nose and down the back of the throat, and it stops the tongue from blocking the airway. These are oropharyngeal airways. You measure them from the jaw to the angle of by the ear, because they come in different sizes. And these ones you kind of slide in. Again, these are to help with bagging if you're doing rescue breaths for a patient, and they just keep the tongue from going down in the bottom of the blocking the airway. Okay. I'm not sure, Mike, what PTL means.
It was one of the older airways. So
okay.
I thought they were still using them, but never mind.
Okay, that's all right. Some of the ones, even like King Airways and some of those other ones, LMAs, you don't see as often anymore. All right. So these are artificial airways. So basically the patient is unable to maintain their own airway, and we have to put an airway in to maintain adequate ventilation or oxygenation, or to be able to get secretions out. Okay, so that's kind of why we put airways in. So they usually have a called a glidoscope, or they can use a scope, and basically they put a scope in, they push down on the jaw and push the tongue back, and they can actually see where the vocal cords are, and they want to put it past the vocal cords at the level of the carina. Okay, and that's why intubated patients should not be able to talk. If they can talk to you, you have a problem because it should be past their vocal cords and they shouldn't be able to make any noises, verbal noises. Okay, so yeah, if they're talking to you, either the tube has moved, there's a leak, or they're partially extubated. And there's a problem if it has moved. And I have had patients cough out their tubes before, and they start talking to you, and you know you're in trouble. So not a good thing. All right. So indications would be if you had some kind of an airway obstruction related to trauma. Burns would be burns around the face, head, or neck. If your patient's apneic, they're not breathing on their own. They can't protect their own airway. Maybe they have a significant head injury, or maybe they have a low Glasgow Coma score and they're neurologically impaired. Maybe they're high risk for aspiration. So aspiration pneumonia is one of the worst types of pneumonia because if you aspirate, it's acidic, right? We talked about vomiting. That's acidic. So not only do you get a pneumonia, but you also get burning and a chemical burn from what you aspirate. So aspiration is bad. If you're unable to clear your own secretions, you may need help. And then any acute respiratory distress. Okay, so we talked about respiratory distress, ARDS, severe acid-base imbalances. Those are all indications for needing an intubation or some kind of an artificial airway. Okay. So this is kind of that paper, that one kind of single handout that I put in the module. So this is looking at rapid sequence intubation. In clinical, they'll call it RSI. Okay, so they use abbreviations for it. So basically, there's kind of a recipe or an algorithm that we follow to intubate a patient. So you want to make sure that you have the correct equipment there. They need to be on a heart monitor. They need to be on a continuous pulse oximeter. BVM is bag valve mask, and that is your ambu bag, okay, which is right here, this blue bag. And that hooks to the oxygen on the wall. Make sure your oxygen is turned on the wall, okay? I've been in codes where they're bagging people and they didn't turn the oxygen dial on the wall. And then consider C-spine immobilization. So this would be if you have a known cervical spine fracture, or if your patient's in a trauma or something like that, you want to do the jaw thrust method. You don't want to displace their neck. Okay. Pre-oxygenate with 100% oxygen. So this is where you're bagging them. Okay. You don't need to give that whole large bag. This large bag holds about 1 liter of air. You only need to squeeze the bag until it's about a half, okay? And what you're looking for is, does their chest go up and down? If their chest rises and falls, that's enough, okay? You don't have to do a big squeeze, okay? Because then you're going to cause trauma, and a lot of air is going to go in their stomach, and they're going to start throwing up, okay? So you don't want that. You want to make sure that you have some kind of a sedative and paralytic. Typically, the code team or whoever's intubating, your emergency room physician or ICU physician, will tell you what they want. Versed or midazolam is kind of a nice go-to. Ketamine is another popular one, or etomidate is another popular medication. Okay, Valium, not so much, but usually ketamine, etomidate, or Versed, those are kind of your nice go-tos. And then these are your paralytics. No, you don't need to memorize the sedatives. Just know that they need a sedative, because you don't want to paralyze someone without giving them some sedation. That would be really cruel. Okay, so some of the paralytics would be succinylcholine or Sux, and then rocuronium, vecuronium. So again, if you kind of remember your family names for medications, oniums, those are all your paralytics, okay? Because you want to make sure that you're paralyzing those vocal cords so you can get the tube down to where it needs to be, Okay, so get your equipment, make sure you're doing good spine immobilization, oxygenate your patient, give them a sedative, give them a paralytic, and then the physician's ready to intubate. So they're going to go ahead and intubate. Sometimes they'll ask the respiratory therapist to apply cricoid pressure, which is kind of right here, to kind of help with the tube. Some don't. What's your question, Stephanie?
Can you help me understand what you said? You would want to make sure you give them a sedative before you paralyze them. What does that mean?
So if I give someone a paralytic, it means they can't move or they can't breathe, but they would be awake if I didn't give them a sedative. Okay, so you want to make sure that you're putting them to sleep and sedating them first before you paralyze a patient. Does that make sense?
Yes, thank you.
Yeah. Okay, perfect. So once you're ready to intubate, the physician is going to intubate. Some hospitals, respiratory therapy can intubate, EMTs can intubate. So it just depends on your scope of practice, okay? But typically in the hospital environment, it's the physician, okay, that's going to do that, or RT. So your responsibilities after intubation is checking for placement. Okay, and I don't think they have it on here. There's a little square device that you put in between the tube and the bag, and it's called an end-tidal CO2 detector. Okay, and it's got a litmus paper in it. When you ventilate someone, okay, you're pushing oxygen in, you release the bag, CO2 is going to come out. CO2 changes the color of the CO2 detector, and that's how you know you're in the right place. Okay, so CO2 detector is your gold standard for looking for placement of your endotracheal tube. After that, you're going to look for chest rise and fall, make sure it's equal. Listen in the abdomen to make sure you don't hear air entry in the belly. Then listen to the lungs. And then eventually the last one really is chest x-ray, because you're going to do all of these kind of very quickly, all done at the bedside, whereas x-ray has to come up and they'll shoot a chest x-ray and verify placement. Okay. Once placement's been verified, they're going to secure the tube with either a holder, kind of like this, or tape. On the tube itself, there's little black marks. They're in centimeters. And you need to know where it's at the teeth or the lips, wherever they measure, because you need to make sure that your tube doesn't move. Okay. All right. Any questions on rapid sequence intubation, what your role is as the nurse, what you should be looking for? All right. We will move on. Maybe. There we go. So there is a difference between adults and children. Children have a shorter airway and they're anatomically different than adults. So typically children, I wouldn't really say 8. I would probably say more like 3. It's a lot younger because kids seem to be bigger than they used to be. But younger children, they will not have a cuff on the end of the tube. So adults, the endotracheal tube has a balloon on the end of it. Okay, and we inflate the balloon with 10 cc's of air to keep it in place, whereas kids do not have the balloon on the end. They do not have the cuff, and it's because their airways are anatomically different. Okay, so if you work in a PICU or have kids in the ED, if you have an intubated kid that does not have a cuff tube, they cannot be left alone ever. You can't go to the bathroom. You can't go to the med room. You always have to have someone in the room. So when I did like peds trauma ICU, the babies are super cute because they suckle on the endotracheal tube. And it's really cute because it moves in and out as they suck. But the problem is if they suck too hard, it can displace the tube. And then you can end up with a right main stem where the tube isn't at the bifurcation. It's only going to the right lung. So that's why you never ever leave your kiddos alone if they have an uncuffed tube. But they are super cute. They suck on the little thing. Very, very cute. All right, so that's the difference between kids and adults. All right, so sure.
Sorry. So you said kids don't use the cuffed ones?
Correct.
Ever?
It depends on their age. So it's babies. So I'm saying like kids less than 2 years old, 3 years old, little kids, because again, their airways are a lot shorter than adults are. Yeah. Yeah. So risks of oral intubation, you can chip their teeth. They can vomit when you're putting it in. They can bite down. They can, you can push obstructions down if they have saliva or anything blocking or anything like that. So you really want to make sure that you're providing really good oral care, have suction available at the bedside. Go ahead, Michael.
What's the word on dentures now?
So
Do we
you
take
want
them
to
out
try
or leave them in?
if they're stuck in, like if they have denture bond in there and they are stuck in there, leave them in. If they're floppy and they're easily removed, take them out. Okay, so it just depends. Some people are, they're tight in there, but some are kind of floppy. So you'd want to take those ones out. Again, you want to make sure they have adequate sedation. If your patient is biting or if they're seizing, sometimes we can put a bite block in. It's like a little piece of plastic that stops their teeth from biting down. You see this little tube right here? This is called your pilot tube. And this is the tube that inflates the balloon at the end of your endotracheal tube. Okay. And if they bite this, you'll lose your balloon. Okay. There are repair kits that you can repair it with, or they would have to replace the whole tube. Okay. So you don't really want them biting. And if they're biting, that means they're not sedated enough, right? Because you don't want to be awake. It would be too much. All right. So in addition to oral intubation, you can also nasally intubate. In like 28 years of bedside, I think I've seen 2 or 3 people nasally intubated. It's not common. It's usually there's something wrong with their oral cavity, and that's why they need to be nasally intubated. But again, it's not commonly done, okay? But you can nasally intubate. Dislodged tube. So again, you want to make sure that the endotracheal tube is ventilating both your right and your left lung, but sometimes they become dislodged. Either the patient coughs, it gets pulled on the side rail, anything could happen where the tube could get dislodged. If your patient dislodges their endotracheal tube, it is considered an emergency. A lot of times you would need to call a code because you need someone to re-intubate your patient, okay? So it is an airway emergency. Your patient's at risk for a pneumothorax, so you need to stay with your patient, call for emergency help. You need to support their ventilation, okay, because they're not going to breathe on their own. So you need to get that bag mask valve, that ambubag from the head of the bed and bag them with 100% oxygen. Okay, so this is kind of what you do if your tube is dislodged. Stay with your patient, activate your emergency response team, bag your patient. Okay, so again, anytime you're looking at questions, and I did put it was a nice little video on how to answer questions and how to prioritize. Always think of your ABCs, right? You want to secure your airway, breathe for the patient, and then activate your emergency team. Okay, so whenever you're looking at which one you would do first, that's what you're going to be looking at for emergent situations for these questions. Okay. All right. So maintaining proper cuff inflation. Typically respiratory therapy does this. Again, this is your pilot tube right here. This is a manometer, and it tells you how much pressure is in this balloon. So this balloon is what's up in your trachea, and you have a lot of arteries that are in your trachea. So if there's too much pressure in the balloon, you can start eroding your arteries down. So they usually come in and they'll check the pressure for you. Okay, it's typically not a nursing function. Respiratory therapy does it. Okay, but they usually check it and make sure that it's okay. Again, if you have a cuff leak, okay, and I think that was one of the questions this week. So this is your cuff right here. So if it's not inflated correctly and you have a cuff leak, that means gas is escaping. Okay, so you're not going to get the correct amount of volume to ventilate. Okay, and you'll get a low volume alarm on your ventilator. Okay, because this is deflated. You have a cuff leak. Okay. All right, so for monitoring, you do want to do ABGs. Typically, they do them daily, and then as needed if they're making changes. You want to monitor continuous oxygenation, so on your O2 sat monitor. Sometimes they'll do end-tidal CO2 monitoring or capnography, but not on everybody, just because they don't have enough equipment. You want to be looking at your respiratory rate and your rhythm, okay? The quality of your respiratory work of breathing. So we talked a lot about that last week. Use of accessory muscles, right? This is all ventilation. And then you want to be looking for signs of hypoxia, that restlessness, anxiety, color changes, things like that, okay? So you want to make sure that you're maintaining patency of your airway. So you want to make sure that it's staying clear and clean. You want to be looking for any alarms on your ventilator. If you have a peak inspiratory pressure alarm, a PIP, it means that there's something wrong with your tubing. Either your patient needs to be suctioned, the tubing is stuck in the side rail, there's some condensation built up because again, there's a humidifier attached to the ventilator and you get condensation in your line, but there's some kind of a problem with your tube, okay? That would be your peak airway pressure alarm. And then again, you just want to look for coughing. Do they need to be suctioned? Do they need more pain medication? Do they need more sedation? Do they just need some emotional support and say, just, slow your breathing down. You're doing okay. Those kinds of things. Okay. So just kind of watch for those when you're looking at your tubes. There's different types of suctioning techniques. Most of them have inline suction tubes where it's built in. If you're using an open technique, you would just do it the same way as you would do your tracheostomy suctioning. Did you guys do trach suctioning in lab? Yeah. Okay, so you would do it the same way. And then you always want to make sure that you're suctioning the back of their throat. So you can use a Yankar for that. Okay. So potential problems from suctioning, again, hypoxia. So you don't want to suction for more than 10 seconds. You can cause bronchospasm. So again, you want to make sure that they have enough pain medication and sedation on board so that it's not too uncomfortable. Just be aware when you do suction neuro patients, it will increase their intracranial pressure. So if their intracranial pressure is high, just be very careful with your suctioning and expect for it to go up, but make sure that it comes back down. Dysrhythmias are typically related to hypoxia. So it's usually tachycardias that you'll see for dysrhythmias. Changes in their blood pressure. So whenever you suction patients, you're changing the pressure in their chest, right? You're changing into thoracic pressure, and you'll see blood pressure changes because of that. If they're too awake on the ventilator, sometimes they'll become really hypertensive. So you want to make sure they're not completely paralyzed, But you want to make sure that they're comfortable, okay? And then you can always cause pain, bleeding, and then again, infection is a big concern if you're not using a sterile technique. So you want to closely monitor your patient. You don't need to have the suction canister turned all the way up on the wall. You only need it to be between 80 and 120, okay? It's usually green on the suction head on the wall. If they have dysrhythmias, stop suctioning and oxygenate your patient, okay? So if your patient ends up having some kind of an arrhythmia, stop what you're doing and make sure that you're oxygenating them. So again, ABCs, make sure that that oxygen is being given, okay? You want to make sure you have adequate hydration so they don't have super thick secretions. No installation of saline. You see this all the time in clinical, okay? They have those little saline bullets and you'll see respiratory put them in the tubes and squirt it down their tube and then go in and suction it out. Again, old practice. What that does is if I squirt saline down their tube to kind of thin out their secretions, what it does is it just sprays all that mucus to the other areas of their lung fields, okay? So it's a no-no. If you have thick secretions in the tubing, yes, you can irrigate the tubing, but don't squirt the saline down the tube, okay? Antibiotics you're going to give, again, if they have some kind of a respiratory infection, mobilize and turn your patient. So they should be turning a minimum of every 2 hours, side to side, and they should be getting up to a chair if they're hemodynamically stable. Okay, so if their blood pressure, vital signs are stable, their heart rhythm stable, you should try to mobilize them. Sometimes you can dangle them over the side of the bed. And if you work in a really good hospital, you'll be walking patients on a ventilator. Okay. You want to brush their teeth twice a day with a toothbrush. You want to do oral swabs. So I know in your textbook it says hydrogen peroxide. Again, this is old. We use chlorhexidine. Okay, so chlorhexidine is the oral swabs that we use, and you should be doing oral swabs and cleaning their mouth every 2 hours, brushing their teeth twice a day with a toothbrush. Mouth moisturizer. This is one of my big pet peeves from nursing. The kits come with a little mouth moisturizer pack in it, and I would see nurses putting it on their lips. I'm like, no, it's not a chapstick, it's for their mouth. You put it on their mucosa, on their tongue. Okay, so that was the mouth moisturizer. Stephanie, go ahead.
So just to clarify, there's a chlorhexidine that is specifically for the oral cavity because it's usually like a topical use, right?
Right. So like for pre-op patients, you have chlorhexidine soap. For these types of patients, there's a oral mouthwash that is chlorhexidine.
Okay.
Yep. Yep. And then you want to make sure you're doing oral pharyngeal suctioning. So again, you want to suction the back of their throat because secretions pool back here. Sometimes the endotracheal tube will have an extra suction tube on there called a high-low tube. And you can hook that to suction. If it doesn't, you have to go back and suction the back of their throat every 2 hours as well. Repositioning and retaping the ET tube. Verify if it's nursing or respiratory that does that. Some places I've worked, nursing does it. Some places I've worked, respiratory does it. But every shift, the tube needs to be changed position. So if it's in the center of the mouth, you would need to change it to the right or the left and then retape it. And what that does is it prevents skin breakdown in the oral cavity, okay, because you've got that pressure there from that tube being in your mouth all the time. So you do need to change positions of the tube and retape it, okay. So methods to decrease anxiety, you want to always communicate with your patient. Let them know what's happening. If you need them to slow their breathing down or breathe with the ventilator, use your therapeutic communication, explain to them, the ventilator's helping you breathe right now. Just try to relax, take slow breaths, those kinds of things, and kind of just calm them down. Make sure they have enough pain medication on board and sedation medication on board. There is a ICU pain score called the CPOT, where you get numbers for like grimacing, numbers for movement, all those kinds of things, and that'll give you a pain score. And then you can also look at your RAS score for sedation. Okay, so you want to use your pain scales and your sedation scales. You have to document both with your vital signs. Okay. And then aspiration, you want to make sure that you're preventing vomiting. So typically, if you have an endotracheal tube in, a lot of times they have an OG or an NG tube in as well. Okay, and that's just to deflate and decompress the stomach so that they don't vomit. This is that high-low tube. You see the yellow end on it? That's the one that I was talking about. So this is a subglottic suction. This is your endotracheal tube right here. And this is your pilot balloon that inflates the balloon right here. Okay. So these are some definitions that you kind of need to know so that you can kind of understand what we're talking about when we talk about the ventilator. So tidal volume is the amount or the volume inhaled and exhaled with each breath. So when we take a breath in and take a breath out, we pull in a certain amount of volume. So usually you're looking at a tidal volume of 500 mLs. So usually it's between 400 and 600 mLs. Okay, so it's the amount of air that we're taking in with each breath. Respiratory rate is just that. It's your frequency. So on the ventilator, it's indicated by an F. Okay, so it's the frequency of breaths per minute. And then your minute ventilation is how much air is moving in and out of your lungs every minute. Okay, and again, one of those handouts has some of those definitions on there as like a one-pager. PEEP stands for positive end expiratory pressure. Okay, it's the amount of pressure that we have left over at the end of exhalation that keeps our alveoli open and stops them from collapsing. Okay, PEEP is very important. PEEP helps with oxygenation. Okay, so if we go back to this slide, this is ventilation, right? It even says it has ventilation in the name. Okay, so respiratory rate, tidal volume, this is the things that I change if I want to change the way my patient is ventilating, my CO2, okay? PEEP, an O2, an I ratio, this is oxygenation, okay? So positive end expiratory pressure will help with oxygenation. This is my FiO2, how much oxygen I have. And this is the ratio how I breathe. So normally I breathe on a negative pressure system and my inhalation is shorter than my exhalation. So just take a minute, close your eyes, and just think about breathing in, breathing out. When we breathe out, it's longer than when we breathe in. I can change that on a ventilator. So if I have a patient that's in ARDS and they are profoundly hypoxic, and I've gone as far as I can go with my PEEP and my FiO2, I can make them take a longer breath in and a shorter breath out. And I can change their inspiratory-expiratory ratio. If you're changing your IE ratio, your patient must be paralyzed, okay? Because you're changing the mechanics of their breathing. We do not normally breathe that way, okay? All right. And then these are some indications for putting someone on the ventilator, which we already kind of talked about a little bit. So if you have altered level of consciousness, so you have a Glasgow Coma score 8 or less, a traumatic injury, so you're putting them on a ventilator for support. Maybe they had a heart attack or some kind of severe event. Maybe your patient's hypoxic, they're in acute respiratory failure. They can't handle their airway or manage their secretions. Or maybe they have CHF, okay, or some other kind of respiratory failure. All right. So I'm going to pause for a second and share my screen, and we're going to watch a video about PEEP so that you can understand the concept of how PEEP helps with oxygenation. Okay.
Actually, I want to do this one without PEEP first. Okay, so I just intubated this pig. And you did a great job. Like that? It was very quick. I RSI'd this time. I'm going to bag this up. It won't explode. Sounds like a challenge. This is called recruitment. See what we're doing here? We're starting to recruit all these alveoli. And I've got to really bag hard to keep these lungs inflated. Okay, and then it goes down. All right, that is without PEEP. Okay, so what we want to do is we want to maintain the reason we use PEEP is to maintain recruitment and provide better oxygenation. So I'm going to dial this in with 5, and then I'll show you with 10. TSW. Now see that collected blood?
Yep.
And then spread that up a little bit more. Okay. That's 15 of PEEP now. Wow. So see what a difference this makes for our patients?
That's insane.
Versus.
So what's an adult for that? What should we set that up for an adult?
Start at 5. So, and there's
you have to really be careful because you don't ventilate the patient.
Yeah.
Should have recorded that.
So start at 5. Check your ventilation on.
I got it.
5. If you need more than that.
Yeah. What will we see with end tidal okay if we need to dial it up?
You're not going to.
Okay, so that was PEEP. Okay, so again, those video links are in the video link section, so you can have a look at those. But basically, we have about 3 centimeters of PEEP all the time that keeps our alveoli open and stops it from collapsing. So a lot of times what we do on the ventilator is we'll put patients on 5 centimeters of PEEP as kind of a standard, and then we go up from there. So then we would go up to 8 centimeters, 10 centimeters, 12, 15, as they need it to help with oxygenation. It helps with alveoli recruitment. The problem is, the more I increase PEEP, it's going to drop my blood pressure because I'm increasing intrathoracic pressure, and it can also, correct Stephanie, it can also cause barotrauma and pneumothorax. Okay, so that's the problems or the complications with PEEP. So you really kind of have to balance it and really kind of put them on enough so that they can oxygenate, but not too much to cause a complication. Okay. All right. So there's different types of ventilation that you can have for patients. There's mechanical. First, we'll start with mechanical ventilation and non-mechanical ventilation. So the other thing I want to show you guys is a type of non-mechanical ventilation, okay? And that is called Airvo. So, and I'll type it in here. There's an app called Airvo 2, okay? And it's free to download. So again, I'm going to share my screen and I'll show you Airvo. All right. If someone wants to stay on mic, I'll just pick Stephanie because when I share my screen, I can't see the chat box if you have questions. Okay. So let me find my Airvo.
What am I doing? What happened?
If anyone has questions in the chat box, just let me know because when I share my screen, I can't see the chat box anymore.
Oh, okay.
Yeah. So this is Airvo 2, and this is a really nice app because it's got a bunch of stuff in here, okay? It has tutorials in here. Again, it talks about oxygenation, how you set up the machine. It has videos in here, and it has troubleshooting in here, okay? So this is high flow oxygen. You may have seen it in clinical, you may have not, okay? So this is the on-off button. So I'm going to turn it on. And it goes through a self-check. So this is through a nasal cannula, but it's high flow. And we'll kind of talk about the different settings when it kind of gets set up here. So it has a humidifier on it, and then it just has a nasal cannula. It does not have a battery pack. That's the problem with this. There's no battery to it. So your patient really is kind of stuck as long as their tubing is because you can't really ambulate with it. Okay. And there's 3 different settings on here. Okay. This first one is the temperature setting. So it's how warm you have the humidity set. Typically you have it set at 37 degrees. So it's going to kind of go up to 37. You can always turn it down if the patient tells you the flow is too warm. Sometimes it bothers patients. This is your flow rate. Okay. This is ventilation. Okay. Work of breathing ventilation. This is my oxygenation, how much FiO2 I'm giving my patient. So if I have a patient and their work of breathing is going up or their CO2 is high and they're acidotic, I want to give them more flow. So these are my indicators right here, and this is how I change it. So I want to click right here to change my parameter. I'm not changing my temperature. I'm going to change my flow rate, my work of breathing, ventilation. You have to click these, hold these 2 buttons down. So I'm going to click right here for like 3 seconds. And the highest it goes is to 60 liters. So I can increase my flow to 40, 50, usually go by 5s and see how the patient does. But the most you can set your flow rate is 60 liters, and then you hit enter. Okay, now it's locked. But what if my patient's desaturating? My desaturation, my oxygen again is on the wall, right? This is my machine. This is what I'm looking at, the platform right here. So maybe I want them to be on 40%. Okay, so now they're on 40% oxygen. Maybe they need to be on 50%. So again, I would increase the oxygen until I get the FiO2 I'm looking for. And then I would save that. And then here's my home screen, which is right here. And there's my temperature, how warm it is. Here's my flow rate, my ventilation, and here's my oxygenation. Okay. And this is kind of what the machine looks like. Okay, so this is a water reservoir. that heats the air. This connects to your oxygen on the wall, and this is your nasal cannula that goes to your patient. Okay, so that is Airvo. Any questions on Airvo? This is high flow oxygen, non-invasive ventilation.
I actually have a question on it. So you said there's no batteries in it. If
correct,
for some reason the electric went out and then the backup generators went out, like what would happen to the patient? Would they just die?
No, you have to put them on a 100% non-rebreather mask, but you would lose your flow.
Okay.
So they won't do as well. And that's kind of what we do. So if someone's on high flow and they need to go down to radiology, I would put them on a 100% non-rebreather for transport. I would take this with me, plug it in when I get downstairs and put it back on.
Oh, okay.
And then unplug it when I'm ready to come back upstairs, put them back on a 100% non-rebreather mask, unplug it, go back upstairs, plug it back in and put it back on.
Okay.
Okay, does that make sense?
Yes, thank you.
Yeah. All right. Any other questions on high flow? So again, flow, this is your ventilation, this is your oxygenation. But again, this is a really nice app because you can kind of play around with it. There's warnings right here, so I can select a alarm. So let's select an alarm. We'll do check for blockages. Okay, so here's my silence button right here. And then I'm going to click right here, and it's going to tell me, oh, I've got, check for blockages. So this is the real machine. This is kind of how it works. So it's a really nice app to kind of play around with because you can change the alarms. So you can see how to troubleshoot it. So again, you want to make sure that the prongs are open on the nasal cannula, those kinds of things. Check water is another one that you see a lot. And again, it's this reservoir of water needs to be full. And then there's usually like it needs to be clicked into place. So it kind of tells you what to check. And this is your reservoir of saline. Okay.
Professor Richardson?
Yeah.
Melissa's asking for clarification. Does the respiratory therapist or the doctor decide on high flow or not? Or is that right?
The doctor needs to order it. However, a lot of facilities have a protocol and an algorithm to follow for titrating it. So the doctor would order it, and then the settings. Let me just take this off. The settings, these are changed per protocol, and that's per nursing and respiratory. So if I'm working at the bedside and my patient's actually doing really well, their respiratory rate is maybe 18, their SATs are 98%, I'm going to call respiratory and say, hey, so I don't make the changes because this equipment belongs to respiratory, but I'm at the bedside. I'm going to call respiratory and say, hey, Mr. Smith's doing really good. Can you turn his flow rate down on his Airvo? Okay, and respiratory will say, sure. They'll come in, they'll click over to flow rate, and then 1, 2, 3, and then we'll turn him down, and we'll start weaning him. Okay, maybe I don't need the oxygen. So again, I'm going to go over to the wall, and maybe I can wean him down to 45%. Okay, so these settings right here are not ordered by the physician. These are typically per titration by respiratory and nursing, and a lot of times, again, you have a recipe or an algorithm that you follow, and it's in the policy and procedures. Okay. Any other questions on Airvo, high flow nasal cannula? Okay. All right. So that is Airvo. Okay. Other types of non-invasive ventilation would be BiPAP and CPAP. Okay. I'm going to skip some of these. Some of these are old. This is negative pressure. This is like the iron lung kind of thing. We don't do that anymore. So CPAP and BiPAP. All right, this is kind of BiPAP. This is what your BiPAP machine looks like. CPAP is continuous positive airway pressure. You get one pressure for your whole ventilation cycle. Okay, so it doesn't help with very much. It only helps kind of with maybe like sleep apnea, something very simple. BiPAP is bi-level positive airway pressure. I have an inspiration pressure and I have an expiration pressure. I have IPAP and EPAP. IPAP stands for inspiratory positive airway pressure. EPAP stands for expiratory positive airway pressure. So I can control ventilation and oxygenation with BiPAP. I cannot with CPAP. Okay, so I'm going to share my screen again and we'll watch a video about CPAP and BiPAP, okay?
Non-invasive ventilation is a great mode to help patients breathe better. In BiPAP, you have two main important settings. The first is your IPAP setting. This determines how much volume the patient will receive. If you increase the IPAP, you increase the volume. The next setting is EPAP. This determines how much PEEP you're applying to the alveoli to keep the alveoli open during exhalation. On a blood gas, if the CO2 is high, you can correct that by giving more volume. Also, if the PaO2 is low, you can correct that by increasing the EPAP. So let's do some examples. In this blood gas, the main issue is ventilation. Notice how this IPAP setting created a small volume. So to correct that, increase the IPAP so that the volume increases. This should help correct the CO2. Also, the more you increase the difference between IPAP and EPAP, the more volume the patient receives. So in this example, oxygenation is low, but ventilation is normal. The general recommendation now would be to increase the EPAP. This should help bring the oxygen back to normal. Be careful when you increase the EPAP, because as you fix oxygenation, you may actually reduce volume. You can compensate by increasing the IPAP simultaneously with the EPAP. Sometimes physicians will write orders like 8/4. Talk to your physician. A better order would be to keep the tidal volume between 300 to 500 milliliters and to keep the saturation in a normal range. That way, you can adjust your IPAP to get your desired volume, and you can adjust your EPAP to get your desired saturation. Well, thanks for watching. Subscribe to my channel.
All right, clear as mud, right? Okay. So on BiPAP, which is typically what we use in the hospital, okay, CPAP is typically those home CPAP machines for sleep apnea. We don't really use them in the hospital to treat respiratory diseases, okay, but we do use BiPAP a lot. So in BiPAP, you have two pressures. You have IPAP, which is your inspiratory pressure. That is ventilation, okay? That is your CO2 and your pH. Ventilation is IPAP. It will give you a higher tidal volume, a bigger breath, okay? Then you have EPAP. EPAP is oxygenation. It's like PEEP. It's your positive end expiratory pressure. So what it does is it recruits the alveoli and keeps them open with more pressure at the end of expiration, which improves oxygenation. And that's why I wanted to start last week by really separating out ventilation and oxygenation, because we treat them very, very differently. Okay, so IPAP is ventilation, gives you a better tidal volume, a better breath. Okay, CO2 pH. EPAP is oxygenation. It's going to give you a better PaO2. Okay, better O2 sats. All right, and that's kind of how BiPAP works. Okay, it's got those two pressures.
Two
Go ahead.
questions. You said CPAP only does which one?
It's one continuous pressure, so you typically only see it with sleep apnea.
Okay, and then would we as nurses typically be handling these types of machines, or is this something that respiratory therapists would come in and handle?
Respiratory therapy changes the settings, but you need to know the mechanics of it because you are at the bedside all the time, and you need to know what settings you're on. Okay. So if you have a patient in the ICU and you have a patient on a PEEP of, so maybe your IPAP is 12 and your EPAP is 5 and you're desatting, your respiratory therapist may not be there. So you need to know to call your respiratory therapist and say, hey, my patient's desatting. They're on 12 over 5. Could you come and increase their EPAP? Or when you call the physician, that's part of that S bar. You know, Mr. Jones came in with respiratory distress. He's on BiPAP 12 over 5. Right now, his SATs are 80%. Can I get an order to change his EPAP? So that's the conversation that you would have. So you do really need to know and understand the concepts behind them because you need to know what to ask for. Even though, yes, it is respiratory's machine. And as a newer nurse, people will always help you out because it's very overwhelming. And respiratory is really good at helping you. But you need to recognize when you need to make that change. Okay?
Thank you for clarifying.
Sure.
I appreciate it.
Sure. Yeah, these are not, they're not easy concepts. They're big, big concepts to kind of grasp. You guys are doing a good job. All right, 5 more minutes here, and then we'll kind of, again, shift to our next class and see how far we can get. I want to see what's coming up here. We're about halfway through. So positive pressure, there's 2 different kinds of ventilation. There's positive pressure ventilation, okay, where you're giving someone pressure like an inspiratory pressure, okay, like on BiPAP, or there's controlled ventilation or volume control. So I can either give someone an amount of pressure to create a tidal volume, or I can give them a specific volume. Okay, so there's different types of ventilation that you can see. So positive pressure ventilation is typically what we see. It's primarily used in acutely ill patient, and it pushes pressure into the lungs to create a tidal volume. If their tidal volume is too low, I need to increase the positive pressure to create a larger volume. Okay, the problem with pressure ventilation is I can have barotrauma from the pressure if my pressures are too high. On the opposite side, if I'm using volume ventilation, if my volumes are too high, I can get volume trauma. Okay, so again, each one has its pros and cons, but most of the time you see pressure ventilation. Okay, it helps with recoil and compliance of the lungs as well. So that's kind of why we use that mode most of the time. So this is just looking at the differences between volume ventilation and pressure ventilation. So again, volume, if I'm using a type of volume ventilation, I'm giving a predetermined volume to the patient. And the amount of pressure to deliver each breath varies, but the tidal volume will stay the same. So the amount of breath that I give them may be 500 mLs. It will always be 500 mLs. Whereas with pressure ventilation, that tidal volume is going to change, okay, because it's pressure, and so the tidal volume is going to vary. Sometimes it could be 450, the next breath could be 560, then it could be, 480. It's going to vary, okay, but there's a predetermined pressure that we give them. So this is on pressure ventilation, okay. So this one, you just have to be careful not to hyperventilate them or hypoventilate them. So you really need to make sure they're getting adequate tidal volumes if you're using pressure ventilation, okay, because it's going to vary. All right, so before we get into the different types of modes, I think this is a really good place to stop. And it's 8 o'clock. So again, we're just going to kind of add these things in. So we'll go through ventilators, and I will add in the delirium next week before we move on to cardiac. Okay. All right. Any questions for kind of what we went through tonight? There is no quiz next week, so it's going to be a full class. And let me check my schedule. I don't think there's any assignments in this class for next week. No homework for this class next week. Okay. Nope, no ATI. Okay. All right. So again, I'll probably do an overview on Thursday, and I'll post that, and we'll just kind of overview kind of what we talked about for today's lecture, and then the leftovers of what we still need to do. We'll finish off this PowerPoint. We have about 30 slides left. And then I'll go through some case studies for ventilators, okay? And then we'll do delirium, and then we'll move on to cardiac, okay? All right, so I'm going to log out of this and skip over to manager of care, and I will see you guys over there.